Greetings and welcome to Mitochondrial Medicine and Chronic Fatigue Syndrome. My name is Dr. John Kaiser. I'm the Medical Director of K-PAX Pharmaceuticals. K-PAX is currently developing what we project will become the first FDA-approved treatment for chronic fatigue syndrome, also known as myalgic encephalomyelitis. The video you're about to watch presents information on the proposed mechanism of action of this novel treatment, as well as preliminary study results. There is a minor technical glitch in the first couple of slides, but after the first minute or so, everything smooths out, and I hope this video presents information that you find valuable. Thank you for your interest. Hello. I'd like to welcome you to a webinar entitled Mitochondrial Medicine, Fatigue, and ME/CFS. My name is Dr. John Kaiser. I'm on the clinical faculty of the University of California, San Francisco Medical School and Medical Director of K-PAX Pharmaceuticals. K-PAX Pharmaceuticals is an integrative medicine pharmaceutical company currently pioneering over-the-counter and prescription medications to strengthen immune function and support optimal energy metabolism. The therapeutic use of all prescription medications I may discuss during this webinar should be considered off-label. Today we're going to talk about the mitochondria, how it functions, and how disease and disorders of the mitochondria can contribute to severe fatigue occurring, especially in patients with chronic fatigue syndrome, abbreviated as CFS. Now, chronic fatigue syndrome has been a disease that has been known and characterized for over 25 years, but there is currently no FDA-approved treatment for the over 1 million patients in the United States with this disorder. Chronic fatigue syndrome may also be referred to as ME, which stands for myalgic encephalomyelitis. So we're going to talk about how the mitochondria functions, and then I'm excited to present to you some results from a clinical trial that I performed on a new potential treatment for chronic fatigue syndrome that K-PAX Pharmaceuticals is currently developing with the goal of FDA approval. Now, when I first started being interested in how the mitochondria works was during the first half of my career when I was a specialist in treating patients with HIV and AIDS. When HIV and AIDS first became known, it was similar to chronic fatigue syndrome. It was a serious disease with no FDA-approved treatment. But eventually, a few drugs made it to market, and those drugs were eventually found to produce severe mitochondrial toxicity. And so in an effort to help my patients avoid these terrible side effects due to mitochondrial toxicity from the drugs, I became an expert in mitochondrial functioning, mitochondrial medicine, and sought to come up with a way to enhance and protect mitochondrial functioning. Now, this slide is just a snapshot of all of the incredibly complex reactions that occur inside the mitochondria. And for those of you who don't know, the mitochondria is the part of the cell that generates all the cell's energy. So every cell in your body, for it to perform its function, it needs to have healthy mitochondria to convert the food you eat into energy. So I'm going to try and simplify what's going on in this slide even further and present to you what I call Mitochondria 101. So if essentially what goes on in the mitochondria is the burning of dietary carbohydrates and fats, which can be thought of as the fuel that goes into the mitochondria, it's combined with the oxygen that everyone breathes, And when oxygen and fuel are mixed together, you essentially are burning the fuel. So inside every one of the mitochondria, and there are between 300 and 1,000 mitochondria in every cell of your body, is a little fire. It's like a furnace, and it's burning carbohydrates and fats, combining it with oxygen, and producing the first step in energy production is the production of what are called hydrogen ions. And these hydrogen ions will go on to be combined with other compounds to form energy. But the other thing that's going on when you burn fuel is that you produce waste products. And those waste products can be thought of as the smoke and the ash of this fire. And those are known as free radicals. So I'll come back to the free radicals in just a moment. Back to the hydrogen ions. These hydrogen ions go down what's called the electron transport chain and are converted into a molecule called ATP. ATP is the energy currency of the cell. All cellular work requires ATP to enable the cell to perform its function. So for a heart cell to contract, it requires energy in the form of ATP. For a brain cell to think, requires energy in the form of ATP. For an immune cell to protect you from disease and infection, requires large amounts of ATP. So by burning fuel and combining it with oxygen, producing hydrogen ions, and ultimately producing ATP, the mitochondria produces all the energy that your cells require to perform their function. As part of this reaction, in addition to chemical energy, the mitochondria also generate heat. And it's only but from the heat generated in the mitochondria that our bodies are warm-blooded, and we can sit in a 65-degree room and maintain our body temperature at 98 degrees. It's because of the heat being generated within the mitochondria. So if we go over to the other side of the reaction and we look at the free radicals, this is a hydroxyl radical, a superoxide radical, and a peroxide radical. These free radicals cause what's called oxidative stress. And these free radicals, if they are not taken care of and converted into less toxic compounds, these free radicals can produce a significant amount of damage inside the mitochondria. The mitochondria uses lipid membranes and enzymes that are proteins, and the mitochondria actually has its own DNA, and all of these structures are damaged if the level of free radicals is too high. And so fortunately, evolution has produced a system to detoxify free radicals. And that is where antioxidant nutrients and enzymes come into the picture. Antioxidant nutrients and enzymes convert these toxic free radicals into harmless carbon dioxide and water. And if there are enough antioxidant nutrients and enzymes, then the free radicals do not cause oxidative damage. But in mitochondrial diseases, it's been shown that the level of antioxidant nutrients and enzymes falls. And there is an imbalance where the level of free radicals is too high and it causes severe damage to the mitochondria, which ultimately causes the mitochondria to die and cells to die and symptoms of disease. So through mitochondrial medicine, the goal is to supplement the mitochondrial nutrients so that you can restore balance to the system and make the production of cellular damage disappear. And once the system is back in balance, then the body can heal. It's got adequate amounts of energy, fatigue improves, other symptoms improve, and the healing process can begin. So this is a brief overview of the way the mitochondria burns fuel and generates energy, and the damage that can happen if there is not an adequate supply of antioxidant nutrients and enzymes. Now, Beatrice Golomb, who's a researcher in San Diego specializing in mitochondrial diseases, specifically a disease called Gulf War illness, her definition of mitochondrial disease is one that involves multiple symptoms spanning many domains. Now, this is because the mitochondria are in every one of your cells, and every one of your systems depends on healthy mitochondrial functioning. So you can also think of domains as being bodily systems. So if we look at the systems of your body that are affected in chronic fatigue syndrome, well, definitely the nervous system, symptoms of nervous system dysfunction include what's called brain fog, memory problems, decreased alertness, difficulty concentrating. Moving on to another system, the immune system, patients with ME/CFS often have swollen lymph nodes. They've been shown to have chronic inflammation, decreased functioning of different cells, different kinds of cells of the immune system, particularly cells known as natural killer cells. There are many glandular abnormalities in chronic fatigue syndrome. Thyroid dysfunction is the most common endocrine problem in patients with chronic fatigue syndrome. It's been shown that they have disorders of adrenal function, hypothalamic function. There's sleep disorders relating to abnormal melatonin production. So the endocrine system is definitely affected. The cardiovascular system is affected. Up to 40% of people with ME/CFS have gastrointestinal symptoms that are similar to irritable bowel syndrome, diarrhea, constipation, cramps. And chronic body pain and inflammation come under the musculoskeletal system domain. So, as we can see, there are at least 6 different domains affected in chronic fatigue syndrome. Now, a mitochondrial disease mechanism, in my opinion, is one of the only hypotheses that really ties together all of these symptoms with one explanation. Now, there are other potential causes of chronic fatigue syndrome that are being explored, such as viral infections or autoimmune processes, but that doesn't exclude mitochondrial disease because an autoimmune process can cause mitochondrial dysfunction throughout all of these systems. A chronic infection can eventually wear down the mitochondria in all of these systems. So even if mitochondrial disease is not the primary cause of ME/CFS, it can be the mechanism by which all of these symptoms develop. So if we go back to Dr. Golomb's definition of mitochondrial disease as one involving multiple symptoms spanning many domains, and we look at ME/CFS through this window, I think the picture starts to focus and become clearer as this being in this process being involved in causing many of the symptoms of this terribly disabling disease. In addition to this hypothesis, there is a growing body of research evidence that is identifying mitochondrial dysfunction in chronic fatigue syndrome. These studies have shown reduced energy production by the muscle mitochondria, low levels of mitochondrial metabolites such as acylcarnitine, abnormal mitochondrial morphology, which means if you look at the mitochondria from a muscle biopsy of a CFS patient under an electron microscope, you will see that it doesn't appear normal. They are either all shrunken and pitted, or they've blown up to 2 and 3 times the normal size. And this abnormal morphology is consistent with abnormal functioning. Here's another couple of studies which show oxidative damage playing a critical role in the pathogenesis of CFS. Sarah Myhill and Norman Booth and John McLaren Howard published a very good paper showing a reduced production of ATP. Remember, that's the energy molecule that every cell requires. And then most recently, Dr. Shungu and colleagues have shown by looking at the brains of patients with chronic fatigue syndrome using sophisticated MRI scans, decreased levels of glutathione in the brain. Now, glutathione is one of the most important antioxidant nutrients required by the mitochondria to function and to keep the level of oxidative stress down. So there's decreased glutathione in the brains of people with CFS. And then they also found increased levels of lactate. Now, lactate is another word for lactic acid. So if you may have heard that if you run long distances that your muscles can cramp because they don't get enough oxygen. Well, the reason they cramp is because when they don't get oxygen, there's a buildup of lactic acid in the muscle cells. And when lactic acid builds up, it decreases blood flow and the muscle cramps. And essentially, what Dr. Shungu's studies are showing is that this same process is going on in the brains of patients with CFS, and brain fog may actually be similar to your brain having a cramp from having too much lactic acid and not enough healthy blood flow. So there's this growing body of evidence, research evidence, that points to mitochondrial dysfunction as a significant problem in CFS. So if we accept mitochondrial dysfunction as a problem and mitochondrial disease as a potential cause of CFS symptoms, how do we fix this? Well, if we look inside the mitochondria, we see that many of the antioxidant nutrients are all networked together. They rely on each other to function properly. So the question really is, where do we jump in to try and fix this problem? So this is a brief list of antioxidant nutrients that many of you have probably heard of before. Zinc and selenium, vitamin B6, also known as pyridoxine, vitamin C, vitamin E. So if we're trying to fix mitochondrial dysfunction, how do we do it? Do we just supplement high doses of 1 or 2 or 3 of these key antioxidants? Do we supplement megadoses of every single nutrient we can think of? So this was the question that I was faced with when I was trying to help my AIDS patients who had mitochondrial toxicity. And so in addition to the experience I had in nutritional biochemistry, I went looking in the medical literature for clues. And one study I came upon, which was performed by researchers at Stanford University, identified glutathione deficiency as being associated with low survival rates in HIV disease. So glutathione, if you recall, is a key mitochondrial antioxidant. and it was being depleted by HIV infection. And so the researchers, in addition to seeing this association, they also identified that the most effective oral way to increase glutathione levels is by supplementing N-acetylcysteine, which the body uses to make glutathione. So N-acetylcysteine is also referred to as NAC, and that became one supplement that rose high on my list as being a very key way to improve mitochondrial health. Another key research study performed by Bruce Ames and colleagues found that if you supplemented acetyl L-carnitine and alpha-lipoic acid to old rats, that it significantly improved the functioning of the mitochondria and at the same time decreased oxidative stress. Now, Dr. Ames is an expert in mitochondrial metabolism. And interestingly, what he found was if the first thing he did was supplement acetyl L-carnitine alone, which acetyl L-carnitine is a natural mitochondrial stimulant. But what he found is that alone, that increased oxidative stress because he was revving the mitochondria. And what he needed to do was to balance the acetyl L-carnitine stimulation with alpha-lipoic acid, which is a potent antioxidant. And so this combination was also added to my list as very important to improving mitochondrial health. Now, I should point out that in addition to being a natural stimulant, acetyl L-carnitine has some other functions that are very beneficial. Now, some people supplement just carnitine alone to accomplish this goal. But it's been my experience that acetyl L-carnitine is a more bioavailable and bioeffective supplement, and the acetyl group on acetyl L-carnitine can also be used for supplying what's needed for methylation reactions. And methylation reactions appear to be abnormal in people with chronic fatigue syndrome. So I'm a big believer that the supplement should be acetyl L-carnitine for these reasons. So after quite a bit of investigation, I came up with this list of key mitochondrial support nutrients. And as you can see, the primary support nutrients are acetyl L-carnitine, NAC to raise glutathione levels in the mitochondria, and alpha-lipoic acid. And the dosages I proposed using were pharmacologic dosages. These cannot be gotten from food in the diet. And these three nutrients are usually not present at all in most multivitamin preparations. But in addition to these three key support nutrients, if you're trying to get the mitochondria to produce more energy, I believe it requires broad spectrum support. You need to provide all the micronutrients the mitochondria needs to function at a higher level. And so this was the formula that I decided to test in my HIV patients with mitochondrial toxicity. And they were really a great group to test this in to see if it could reverse mitochondrial dysfunction. And it actually did. And with the support of funding from Bristol Myers Squibb, I was able to perform a double-blind, placebo-controlled trial of this micronutrient formula in patients with mitochondrial disease. And the results were highly significant that this nutrient formula could improve the symptoms of mitochondrial toxicity and strengthen immune function. This formula eventually was released by K-PAX Pharmaceuticals as K-PAX Immune Formula. And if anybody would like more information on K-PAX Immune Formula, if you Google K-PAX vitamins, it'll come right up and you can learn more about it. You can look at the complete full formula and you can get that information online. So once I found a formula that appeared to produce clinically positive results in patients with mitochondrial disease, I decided to test it in patients with chronic fatigue syndrome. And so I began giving this formula to my patients with CFS as evidence of mitochondrial dysfunction started to come to light. And I was not entirely satisfied with how it worked in its current form, because my goal, especially if one is looking to develop a treatment that can become FDA approved, my goal was to identify a treatment that worked in at least 50% of people that tried it and worked over a short time period, weeks to months, as opposed to taking years to produce the benefit I sought. So I started looking for what I call the missing piece. And over several years of testing in my chronic fatigue syndrome patients, I eventually came to a currently available drug that, given in a low dosage, the drug is called methylphenidate, given in a low dosage, appeared to act as a catalyst to the mitochondrial nutrients. Either one of these by themselves did not appear sufficiently potent and did not give me the results I was looking for, but a low dose of methylphenidate, which is the generic version of Ritalin, appeared to have a synergistic effect. It appeared to act as a catalyst to really enhance the effect of the nutrients. And looking at it from the other direction, the nutrients appeared to make the methylphenidate better tolerated, and it produced fewer side effects. So I know when it comes to prescribing stimulants for people with chronic fatigue syndrome, there is a wide range of opinions. There's a lot of hesitation, and I'll share with you that for over 10 years, I really resisted giving any prescription stimulants to my patients with chronic fatigue syndrome. But in a number of cases that were very severe, when I combined these two components, I saw dramatic improvement. People who had been just barely getting by for 8, 9, 10 years, within just a couple of months were dramatically improved, and it appeared to be very well tolerated. I saw rapid improvements in their energy level, rapid improvements in their alertness and in their concentration, and most importantly, improvement in their functional status, such as going back to work, re-engaging with their families, having children. My patients who I have given this formula to, it has in many cases changed their lives for the better. So other than just giving it to my patients, along with K-PAX, I decided to design a proof of concept trial. So we recruited 15 patients with CFS from the community. None of these patients had ever met with me before and were not following any other recommendations that I may have made. They just came in to try this new treatment for a 3-month intervention, and we collected data in a very systematic way. These are the average baseline characteristics in the proof of concept trial. The average age of the 15 participants was about 45. They had had CFS for an average of 12 and a half years. It was evenly split between men and women. And To gauge and measure the effect of this treatment, we used a questionnaire called the CIS. The CIS stands for Checklist Individual Strength. It's known as a patient-reported outcome measurement tool. It is a questionnaire with 20 questions, similar to the ones you see on the screen. These are the first 8 questions, and for each question, you have a choice of 7 different responses. And if you select the worst response for all 20 questions, the maximum score is 120. The average score in the patient group of this small trial was 108. Anything over 100 is really symptomatic, and normal is 75 or less. So the patient started out with a score of 108. And this is what occurred over the 12-week trial. They started at 108, and within 4 weeks, the overall chronic fatigue syndrome symptoms had decreased by 32%, by almost a third. And then over the next 8 weeks, that improvement continued. And most importantly, 87% of the patients experienced a clinically significant improvement of 25% or more. So this was really eye-opening. And aside from looking at this graph, I saw in many of these people dramatic improvements in their ability to function over just a few month period. The CIS also has a subscale that looks at, and I should say that the average score fell to within the normal range. The CIS has a subscore which looks at concentration disturbance symptoms, symptoms of brain fog and decreased alertness. And when you looked at the data on the subscore for concentration, the improvement at the end of 12 weeks was almost 50%, so even better than its effect on fatigue. And as well, clinically significant improvement in 87% of the group. So armed with this data, we felt confident to design a larger double-blind placebo-controlled trial, which we call the Synergy trial for CFS. It was going to recruit patients at 4 different centers in the United States, compare the treatment to a placebo. Neither the doctors nor the patients knew who was taking which, and we enrolled 134 patients. 50 patients were enrolled at Dr. Jose Montoya's clinic at Stanford University. 18 patients were enrolled at Dr. Nancy Klimas's clinic at Nova Southeastern University in Fort Lauderdale. 28 patients were enrolled by Dr. Susan Levine in New York City, and 38 patients were enrolled by Dr. Lucinda Bateman at the Fatigue Consultation Clinic in Salt Lake City. These 4 research sites are 4 of the best clinics for chronic fatigue syndrome in the country, 4 of the best researchers for chronic fatigue syndrome, and we think they represent a very valid sample of patients with chronic fatigue syndrome. Now, I'm pleased to tell you that this entire study took place in 2014, and all of the patients have completed the trial, and we are just a few months away from receiving the results and the analysis of the data. And so if anybody watching this webinar would like to receive a notification of the Synergy trial for CFS results, you can send your contact information to the email address at the bottom of the screen, ask@kpaxpharm.com. That's ask@kpaxpharm.com. And as soon as the results become public, we will send you a notification and let you know what was found. But we're cautiously optimistic that we will get similar results and be able to continue moving this treatment through development towards FDA approval. What I can share with you are the baseline characteristics of the Synergy trial study participants. These are, this just tells us what the group looks like. So similar to the proof of concept trial, the average age is 43. The female-male ratio in this group was 2.5 to 1, which is much more consistent with other studies of chronic fatigue syndrome and how it breaks down between women and men. The average duration of symptoms was 11.5 years, and the average CIS score in this group was 112, which is slightly worse than the proof of concept trial patients. Now, the only other thing I know that I can share with you today, since we don't have the analysis or the results, is that since the trial has completed, we know that the safety profile was very good. This treatment was well tolerated. There were no serious adverse events that were linked to the study treatment. And so that's reassuring that by giving low-dose methylphenidate along with a potent mitochondrial support nutrient formula, that we achieved good safety data in a large group of symptomatic patients with chronic fatigue syndrome. So like I said, we're just a few months away from the results, and we hope to be able to send you a notification if you get in touch with us. And finally, I really do want to say how pleased I am and thankful I am to the study subjects who participated, knowing that they had a 50% chance of being on a placebo, but this is the only way that we will get FDA-approved treatments for chronic fatigue syndrome is if patients participate in clinical trials. And I'd also like to thank the doctors and the staff at Nova, Salt Lake City, Stanford, and New York City sites. They did a terrific job, and we're very grateful. The final slide that I'd like to show you is a slide which identifies that patients with chronic fatigue syndrome are not the only people who have severe medically related fatigue. Chronic fatigue syndrome is about 1 to 2 million people in the United States, but there are many other diseases whose patients have severe fatigue symptoms that are as severe as people with chronic fatigue syndrome. Most notably, I'd just like to mention patients who have undergone treatment for cancer, chemotherapy and radiation. A large number have been diagnosed with what's called cancer-related fatigue. Chemotherapy devastates the mitochondria and can lead to mitochondrial dysfunction and resultant fatigue. It can also be the process that causes fatigue in fibromyalgia, Parkinson's, Alzheimer's, Gulf War illness. So we're hoping that if this treatment is effective for patients with chronic fatigue syndrome, that we may ultimately be able to benefit patients with these other diseases that also cause severe medically related fatigue. So on that note, my name is Dr. John Kaiser. I'm the medical director of K-PAX Pharmaceuticals. I hope this information has been useful to you, and I wish you the best of health in the future. Thank you for watching.